how things are. But we're going to finish with how things can be and how we can work together to solve some of the simple problems. Because in resuscitation, although it seems very complicated, it's oftentimes very, very simple. Thank you very much. Gracias. So, when we talk today, I think we're okay. I have no conflicts of interest, financial, but I sit on some advisory boards and have some research grants involved with resuscitation. The photos that I'll show you today may have some devices and products in them, but they are not intended to endorse any one of them, just to show them as examples of what's here and what can be done. But if we think about the problem of resuscitation and how big of a problem it is, even though in our clinics and in our practice we may only encounter 1 or 2 children in our lifetime that arrest, or if we're in an ICU 1 or 2 a week or a month, it is a very important problem. In the United States alone, adult cardiac arrests occur 1,000 adults a day, each day, like 2 747 jets crashing and burning with no survivors each day. The same, double that number in Europe. The same, double that number in Latin America. And if we think about children, we think about 2 school buses full of 50 children each, 100 children per day that have cardiac arrests, twice as many in the hospital than out of the hospital. But one of the very important things that is that because adults are old who arrest, and adults have other problems with their heart, and because they have a very short productive lifetime after they're resuscitated, almost 1/3 of quality of life years can be saved if we were to save the children compared to adults. So even though they represent a very small percentage of the number of cardiac arrests, the potential to resuscitate, revive, reanimate, and to improve the quality of life is very important. Oftentimes, people say if you save one child's life, you have saved the world for that patient, for that family, for that community. But unfortunately, the pace of improvement in quality of resuscitation and quality of care has lagged behind for resuscitation. For leukemia, shock, HIV, congenital heart disease, diaphragmatic hernia, mitochondrial diseases, liposomal diseases, the pace of acceleration of improvement in survival over the last 50 years has gone from 95% mortality to 95+% survival. For cardiac arrest, it has been much slower, and we have only seen in the last 5 to 10 years a marked improvement or acceleration in survival and intact neurologic survival outcomes, because we have discovered just a few things that make a difference, and we've gotten better at implementing them. How is it? We oftentimes learn from stories, from anecdotes, our experience. How do we change our practice? We are moving from individual stories to science. The International Liaison Committee on Resuscitation, the American Heart Association, the Latin American Resuscitation Council, and 7 others, which I've been privileged to chair over the last 10 years, are doing a continuous evidence evaluation review of all of the published science in resuscitation. We consolidate that into evidence evaluation and then into training materials and dissemination to the medical community and to the public. And with those advancements, we are making a difference, because the formula for survival is medical science multiplied by educational efficiency, multiplied by local implementation. Those factors are the ones which impact survival and good quality of life. But we have concentrated very much on the science and the training. But the local implementation, as you'll hear, is probably the most important factor that we have not concentrated on, where the biggest impact can be had. We have the knowledge, we have the tools, but can we get it to work in our hospitals, in our units, in our clinics, in our practice? In fact, oftentimes we see that when we go from single center to multi-center studies, when we go and generalize to effectiveness and general practice, we lose in translation about 75% of what can actually happen to what does happen. But if we start to combine clinical trials with registries, audits, and quality improvement, we can start to double the survival outcome of children. In our own hospital at CHOP, we saw this combination when we improved the quality of training and resuscitation and implemented quality improvement techniques. In our ICU, when we embedded our quality improvement into our practice, we doubled the intact neurologic survival from 25% to 50% in our ICU. And so it is possible, but we have to work to make that happen. And now with comparative effectiveness adaptive design, we are moving further to capture the natural experiments that occur in all of our practices and units in order to inform the guidelines, inform the training, and inform the practice. And we have stopped concentrating on just return of spontaneous circulation or survival to hospital discharge, but we are developing what the patients and the families feel is important, which is survival, life impact, economic impact, and functional recovery long term. Is the quality of life preserved? And what we're recognizing, and we'll talk about in subsequent discussions, is that it's not just return of spontaneous circulation that matters, but in those minutes to hours to days following resuscitation, the quality of the care that's delivered impacts neurologic function, executive function, and quality of life. Now we know some simple facts. Everybody knows that children are different from adults. You can look at these photos of this child with a compliant chest, the big head, the large stomach, the rapid heartbeat, the soft sternum, that the techniques we use have to be adapted from adults to children. And most children have normal coronary arteries, and they don't have a lot of arteriosclerosis. They oftentimes have complex underlying conditions that we know a lot about. And so what we do for children has to be different from sudden cardiac arrest in adults, which is generally due to long-term heart disease. In fact, the treatments that we have include airway interventions because the predominance of arrests are respiratory in nature and need a respiratory treatment, particularly before arrest. And those that have cardiac disease or sudden arrhythmias can be readily identified and treated with electrical interventions. We know by our epidemiologic studies that our children are very different. The first breath of life in newborns can save 1 million children worldwide. 1 million children each year worldwide with a simple, effective breath of life at delivery. We know that apnea of the newborn is very important for out-of-hospital cardiac arrest, and simple interventions like the direction or how we lay the children down to sleep can make a huge impact on survival outcomes. We know that those with congenital heart disease, that if we target the interventions, we predict who will arrest, and we have advanced therapies like therapies for pulmonary hypertension and ECMO support. We can now see excellent recovery after cardiac arrest. And we know when sudden cardiac arrest occurs, like with commotio cordis, a sudden blow to the chest of an adolescent, when a soccer ball or a karate fist hits the chest and they suddenly fibrillate, that automated external defibrillators, excellent CPR, and aftercare can create excellent outcomes even when delivered by laypersons in the community. So we know that one size doesn't fit all, but the principles of assessment, of activation, of treatment and quality are all the same. And this photo reminds me that everybody who arrests can benefit from good quality chest compressions. Even hands-only CPR can generate blood flow to the heart and brain to preserve function for up to 10 minutes. And that can give time for other effective therapies. And this slide also reminds me that it is reflection, it is thinking, it is reviewing what we do that makes a difference when we come together in teams, and that is now making quite a bit of difference in resuscitative care. Of course, we know that the perfusion of the heart occurs during diastole. The diastolic blood pressure during CPR is the perfusing pressure of the heart. And so we're paying increasing attention to do excellent chest compressions that deliver a diastolic blood pressure of greater than 25 millimeters of mercury in infants and greater than 30 millimeters in children and adolescents and adults. And this is particularly important when we have an arterial catheter in place in our ICUs, where we can guide our therapies not by simple anatomic considerations, but by physiologic methods that target the blood pressure. When we don't have an arterial line in place, the exhaled carbon dioxide from the lungs reflects blood driven to the lungs, exchanging gas, and the exhaled carbon dioxide of greater than 20 millimeters of mercury signifies adequate blood flow to the heart and brain that is associated with better survival outcomes. And thus we have simple tools that have physiologic measurements that can drive us. But oftentimes we find in real practice they're present but ignored. We are panicked. We are not working as a team. We have not practiced adequately. And we haven't reviewed what we have done in the past in a manner that enables the team to focus on the key elements that make a difference. In fact, when we think about it, over the last 50 years, there are only a few elements in each time period of resuscitation that make a real difference. Before the arrest, to protect, recognizing the risk and the elements of clinical deterioration, and activating a team that can respond to those in an adequate manner can solve many of our problems. In fact, when early warning scores combined with rapid response teams was implemented at Cincinnati Children's Hospital, they noticed a 50% reduction in cardiac arrest in their hospital. In our ICU and our floors, 97% of the cardiac arrests now occur in the ICU because they're identified before arrest on the wards. And so having an expert team available at the time of arrest rather than an inexpert team on the ward can make a huge difference in the early minutes of resuscitation. During cardiac arrest, we must rapidly identify the reason for arrest. Rapid chest compressions and rescue breathing, and determination if a shock is needed. During resuscitation, pushing hard and fast, minimizing interruptions and allowing full chest recoil, while not overventilating, are the 5 elements that are easy to do but often forgotten. And finally, when we have a return of circulation, being able to reanimate or to do very simple measures in post-resuscitation care that are easily done in an emergency department or ICU setting can make a real difference. Goal-directed care. So patient recognition and the implementation of a few simple, basic principles of goal-directed care, and then a follow-up of the important measures focusing on those things that make a difference for intact neurologic survival and quality of life are where we are now. But how will we get there? Alexis Topchin and the American Heart Association recently published in 2019 Circulation a post-cardiac arrest care guideline, which has really focused on specific time points during post-resuscitation management that are quite important. They have identified goal-directed care and simplified it so that targeted temperature management, blood pressure control, oxygen titration, seizure detection and control, metabolic balance, decreasing the metabolic demands of the heart and brain, coupled with optimizing delivery of the substrates, oxygen, and blood flow that are important, and a few special resuscitation circumstances for single ventricle, pulmonary artery hypertension, and right ventricular dysfunction that can make all the difference when done. In fact, Brad Marino and Sarah Tabbitt published in 2018 a compendium, a long list for the cardiac intensive care unit that cares for patients who have unusual cardiac malformations. As it turns out, there are not a lot of differences in the initial management of cardiac arrest, but some few crucial differences in specific congenital abnormalities that can make a difference. So what have we learned? We know that high-quality CPR is actually not very common, even in our advanced ICUs. And we also know that we can take certain blood pressure and end-tidal CO2 and depth and rate targets, and if we achieve the American Heart Association guidelines, better outcomes ensue. We have learned that we can implement this with point-of-care training, rolling refreshers that are low dose and high frequency, and that if we combine the frequent short training with debriefing, reviewing what we're doing in a qualitative and quantitative manner, and feeding it back to the teams that care for these patients, we can double the survival outcomes, even in our advanced centers. And in our research labs and observational studies in patients and multi-center observational studies have demonstrated a strong association of these hemodynamic parameters with survival outcomes. So goal-directed care can make a difference. But what remains to be seen is if in large scale we can actually train our providers and environment to deliver that high-quality care that will save more lives and better quality of life. We have to focus on the individual, on the team, and on the environment. Early recognition and response, having a method, either electronic or manual, to pre-identify children at risk with early warning scores and activation. In our hospital, we use our electronic medical record in order to simultaneously and continuously screen all the patients in the hospital and the ICU for the highest risk triggers for a clinical deterioration that will activate our critical care outreach team to go visit those patients and pull them into the ICU or provide support outside of the ICU before an arrest happens. We identify those children before, during, and arrest who need specific therapies. And why do we do this? We know from observational studies, and now multiple observational studies, that there is an association of post-arrest hypotension with worse odds of survival. We know that detecting EEG abnormalities in background or subclinical status epilepticus is associated with poor outcome. And we know that fever after cardiac arrest is also associated with worse outcomes. We have to go to the translational research lab in order to eloquently discover which of these elements is important at what time frame. And so we are just now starting to tease out what critically important blood flow, nutrient delivery, oxygen delivery, and what organelles need to be slowed down and what need to be improved. And you'll be happy to know that mitochondria are at the center of what we're finding are both the problem and the solution. We know that our goals are currently very crude. We discovered that the association of blood pressure, of a diastolic blood pressure, as I mentioned, greater than 25 in infants, greater than 30 in children in clinical studies is associated with better survival and survival with favorable neurologic outcome. This brings us to study in the lab what it's doing at the organ and organelle and at the cellular and subcellular level. But before we do that, we can develop training tools that enable us to deliver this. So we take what we learn, and now we can use apps, and we can use mannequins, and we can use displays in order to be able to create tools that we can train individuals and teams on how to deliver better quality care based on the tools they have in their environment. In fact, Dr. Falk and others are developing tools to identify the state of affairs of the mitochondria in a static or even an ongoing fashion. Using microdialysis, using non-invasive and invasive sensors, they can detect in the brain and the muscle, the heart and other organs. What is happening at the subcellular level, and how can we improve the delivery of substrate and decrease the demand at the right time to have better outcomes? But at the grand level, think of the problems we have in moving what we know in her research lab to the bedside. At Children's Hospital of Philadelphia, we have 540 pediatric beds. 20% of the hospital is ICU beds. We have 100 neonatal ICU beds. We have 100 pediatric ICU beds. And in my ICU alone, with 65 medical surgical ICU beds, we have 5,000 admissions with all of these different providers. When I count the number of 5-person teams that would respond on a code blue team every day for a child who arrests in my hospital, it results in more than 1 million combination of 5 people who might respond to a child. How are we going to keep them trained? We must have simple guidelines. We must have environments and teams that train together. And we must review what we do so that we can communicate and deliver the type of care. Because the actual things we need to do are quite simple, but getting them done is quite hard. In Philadelphia, we once had a championship National Football League team, the Philadelphia Eagles. And we are trying to learn from them how we take a team of champion individuals and put them together so that they result in a championship team. Because you can have expert individuals who know exactly what to do, but if they don't work together and everybody working in a good functioning team, the result is poor. In fact, in Europe and Latin America, they have discovered how to do this for the football teams, for the race car drivers, where they have clinics and they have cities that they've built to train the championship teams. Why don't we have this for children and for resuscitation? The American Heart Association has released a resuscitation quality improvement program, the RQI program, where they are taking what we learn in courses every 2 years, PALS, ACLS, basic life support, and created online and local rolling refresher carts where every 3 months we can update our skills and continuously refresh our skills. And the next generation of this training will capture what you do in your clinic, in your office, in the ward, and in the ICU, and allow you to include that in your learning management system. So if you do resuscitation as part of your everyday work, you can get credit for it. And you won't have to go to a silly course in the simulation center to get re-credentialed. You can capitalize and do something different, something better in the simulation to push your knowledge forward. We're using different techniques of virtual reality, augmented reality, but also simple things like blindfolds. Here you can see in our pediatric critical care boot camp, the team leader is wearing a blindfold so that he can't see what's going on, and all the team members must communicate with the team leader to organize the resuscitation, to learn how to be better team followers. And in fact, the team leaders are better blindfolded than they are when they can see what's going on, because they don't get involved with and distracted by some of the very simple things they need to do. We review each resuscitation, and we create hot and cold debriefings that have real data from real resuscitations that show the providers there what happened and why, and they can discuss how they did well and how they could improve. And we gather the data and load it into national registries of CPR for in-hospital and out-of-hospital resuscitation, where we are now learning much more about resuscitation practice to move it forward. In fact, at CHOP, we have a data coordinating center from 40 international centers, of which now Cardioinfantil is a new collaborating member. For each cardiac arrest, sending quality of CPR information, pre-arrest information, post-cardiac arrest care, to try to learn from each other how we can improve the care and move the quality forward. We've developed paradigms where before the arrest, we identify the at-risk child and we pre-train the providers. Where during the arrest, we provide real-time feedback using advanced monitoring techniques. And we have a post-arrest, very short, hot debrief, followed by short episodes of pre-training for each shift of care at the bedside to the nurses and doctors and respiratory therapists to prepare them for the challenges that we anticipate they'll find in the next 6, 12, 24, and 72 hours of care for that child, followed by data-driven debriefings and long-term follow-up clinics for these children. Through these techniques, we can generate report cards like this one here that have spidergrams for the process of care compliance for each of the elements of post-resuscitative care. And we can form post-cardiac arrest teams that help the bedside providers provide that excellent care. At Children's Hospital of Philadelphia, we found it was so difficult to accomplish this that we have started to develop and are releasing on November 15th a Center for Pediatric Resuscitation that will pull together the pioneering translational research from the lab, the extraordinary care that's being done in the 40 centers around the world, and the training and support in collaboration with the American Heart Association into a single center, just like the football teams, just like the Ferrari drivers. We can create a system where either on-site or at your hospital we can deliver and monitor the care of the children. From our large animal translational research labs, we are learning the next generation of care and how we will approach it, the tools that we'll use in order to improve the care and outcome using advanced mechanical techniques, the medications and the titration of medications for the future. And by using live capture video in our emergency department and capturing and being able to review real events, we will move the field forward. We now can remotely interact across the world and train. From a centralized telemedicine center, we can run simulators and training sessions in Tokyo, Japan, just back and forth between the two institutions. And we can develop advanced wearable technology like the smart watches, like the hexoskins that the astronauts wear. In this photo, you can see that 2 of the members of our team are wearing near-infrared spectroscopy headbands that are non-invasively tracking the brain blood flow while we run a simulated resuscitation and loading the tasks onto the team leader and the nurse manager and watching their brain blood flow and their NASA TLX performance in order to identify when they become task overloaded and help them understand when they can shovel off tasks to other providers. We're using eye tracking software during resuscitations that are videotaped in our delivery room in order to understand the patterns where experts and novices, how they look at the baby and the monitor back and forth, and how we can improve resuscitation care. We are partnering with our electrophysiologists and our engineers and our human factor specialists to understand how the performance of resuscitation can be reenacted in order to improve performance and develop new tools and displays and wearables that will inform. We are trying to make simpler and easier tools for resuscitation training in lower and middle income countries where they can't afford the fancy simulators. and developing systems like mobile vans that can go out to remote areas to train and test. We're learning how to use social media in order to expand the influence and develop drones to deliver AEDs, stop the bleed kits, and other tools. So for the future, we have to think very simply about how we will use this advanced technology. How can we improve surveillance, early detection, rapid response, team performance, monitoring and coaching, mechanical resources, post-resuscitative care, and most importantly, quality review and improvement. We have many challenges as we move forward towards 2020. How can we teach, learn, remember, act, and act well? But most importantly, how can we impact the lives of those that we care for good neurologic survival and quality of life? It will take a village, not individuals and not individual hospitals. We'll have to work together, and we hope that we can put your photo here. Thank you.
Thank you, Dr. Vinay, for your inspiring talk. I hope all the junior physicians and senior physicians take